Hello and welcome to the Kingdom Strength Podcast. My name is Troy Briscoe, your host, and today I want to talk about tendinopathy. And this is one of those topics that sounds very specific, but actually applies to a lot of different people. Whether we are talking about Achilles tendinopathy, patellar tendinopathy, lateral elbow pain, rotator cuff related to tendon pain, gluteal tendinopathy, proximal hamstring tendinopathy, or some other tendon-related presentation, the principles matter and apply. Tendon pain can be frustrating because it often does not behave like a simple tendon or a simple injury, rather. It just needs a little rest, but a lot of people will feel better for a few days or even a few weeks and return to the same activity. And guess what? The pain comes right back. And that's one of the big reasons why I wanted to take some time to cover this topic, because when we talk about tendinopathy, we're not just talking about pain. We're talking about load tolerance. We're talking about capacity. We're talking about the ability of the tendon and the entire kinetic chain to tolerate, transmit, store, and release force. So the big idea for this episode is this. Tendinopathy is not just a pain problem, it's often a load capacity problem and load management problem when you look at the acute versus chronic workload in the recent history, right? So that being said, though, that doesn't mean that pain is irrelevant. Pain does matter and symptoms do matter. Irritability is what drives us to do something about the matter, right? But if our only goal is to reduce pain and we never rebuild the capacity of the tissue and the system, then we have not completed the job. And before I continue, I want to let you know that I have a slide deck in the show notes that I prepared for a Rehab to Performance presentation about tendon pathology. This slide deck stages the idea of the stages of management, going from desensitization to building capacity, then restoring the energy return and load transfer, and then of course ending with the sport-specific demands at the last phase of the progression scheme there. So that is really the backbone of how I want to think through this today. Feel free to follow along or review the slides at a later time. They're there for you to look over. It's nothing too fancy or detailed. It's just there to provide some sort of framework. Let's kick off by defining tendinopathy. Tendinopathy is typically used to describe the clinical presentation of pain in a tendon with associated dysfunction. And that wording matters. It's a clinical presentation. It's not just an imaging finding. It's not just a tissue label. It is pain plus dysfunction in the context of tendon loading. Historically, a lot of these conditions were described as tendinitis. That implies inflammation, and people started using the term tendinosis. That became more popular, which implies degeneration, but the reality is more nuanced than either of those terms can specify alone, right? Tendon pain and pathology can involve tendon cell responses from the chemical and physiological standpoint, changes in the extracellular matrix, collagen disorganization, vascular changes, inflammatory mediators, altered pain processing, and changes in load tolerance as well. Cook and Purdam's tendon continuum model is one of the most commonly cited frameworks for understanding this, and one of my favorites at the present time. They described tendinopathy as a continuum that includes reactive tendinopathy, tendon disrepair, and degenerative tendinopathy. The value of that model is that it gives clinicians a way to think about different stages of tendon presentation, rather than assuming every painful tendon is the same. In a reactive tendon, the tendon is often responding to an acute overload or sudden change in demand. That might be someone who took 3 months off from running and then jumped right back into sprinting, right? They just jump right back into their running program and exactly where they left off. Or it might be a basketball player who suddenly increased jumping volume. It could also be someone who started CrossFit and added a lot of kipping pull-ups or box jumps or high volume Olympic lifting variations without a gradual buildup. So keeping in mind that acute chronic workload ratio that Tim Gabbett popularized in some of his work. So in that reactive phase, the tendon may be painful, irritable, and sensitive to load. The goal here is to not completely unload the tendon forever. The goal is to reduce excessive or provocative load. Find a tolerable entry point, then begin rebuilding capacity. As tendon pathology progresses, we may see more matrix disruption, increased proteoglycan content, and more structural changes. In degenerative tendon pathology, there might be regions of significant disorganization. But even then, we have to be careful with how we interpret imaging. A really important paper by Docking and Cook makes the point that imaging does not tell the full story. Imaging can show structural changes within a tendon, but tendon abnormalities not on imaging do not automatically confirm that the tendon is the source of pain and dysfunction. And that goes for other tissues as well, like disc pathology or discogenic pain, for example, right? So someone can have tendon pain with relatively limited imaging findings. So imaging has to be interpreted in the context of the patient's history, exam, symptoms, function, and loading response. That is clinically important because we do not want to scare people into thinking their tendon is broken or permanently damaged because an image shows changes. Tendons are adaptable tissues. They respond to load, and they can become more tolerant to said load. They can become stronger. They can regain function. So when I'm thinking about tendinopathy, I'm not just asking, what does the tendon look like? I'm asking, what can this person currently tolerate? What can they not tolerate? And what do they need to be able to tolerate? Looking at where they want to go, keeping their goals in mind. And that is the clinical bridge between pathology and performance. So now let's talk about why tendons can become painful in the first place. We foreshadowed this earlier with the acute to chronic workload ratio, but let's dive into this a little bit more, okay? Tendons are connective tissues that transmit force from the muscle to the bone. That's their function. They go from muscle to bone, as some of you may remember from anatomy class. They're designed to tolerate load as well, and they help transfer force. They help store and release energy. If you think about sprinting, jumping, cutting, landing, throwing, or even repeated gripping and lifting, tendons are central to performance. The Achilles tendon is a great example. It behaves like a spring. It stores and releases energy during running and jumping. The patellar tendon is heavily involved in jumping, landing, deceleration, and change of direction. And the rotator cuff tendons, for example, they help control the humeral head and they manage force transfer during the gripping and lifting, like I just mentioned a moment ago. The common extensor tendon at the elbow is involved with this gripping, right? Oh, sorry, the rotator cuff obviously isn't necessarily responsible for that gripping. That's the wrist extensors, right? The tendon group that attaches at the lateral epicondyle. But when it comes to like the Sherrington's law of irradiation, which if you're a chiro student out there that went to Parker, Dr. Cody DeMack teaches this, where you have the distal activation of muscle and that kind of neuromuscular response. You get that more proximal activation of tissue. So when it comes to gripping, you keep in mind the activation and even mechanics of the upstream effects of said biomechanics and neuromuscular activation and recruitment. But when it comes to function of the tendon groups themselves, you think of the rotator cuff being involved in more like overhead or throwing, and the extensor tendon at the elbow involving grip and repeated upper extremity loading with like gym movements or tennis playing when it comes to that lateral epicondylitis, and golfing when it comes to more of the medial epicondylitis. So anyway, those are just some examples of different tendon groups that can be involved with tendon pathology. Hope that made sense and you followed along well. I know I kind of jumped around a bit going from the rotator cuff and the wrist extensors there, but I think I made my point clear. Moving on to more details about this with tendons being load-bearing structures. They're highly sensitive to changes in load. You kind of got to progress and do this in a slow manner, progressive overload there. So that's a very important concept in this conversation. So when tendon pain develops, like I mentioned earlier, there's a mismatch between the load being applied and the tendon's current capacity. And that mismatch can happen for a lot of reasons. It might be a sudden increase in training volume, spike in intensity, return to activity after some time off. It might be a change in footwear, surface, training style, or sport demands. It might be some involvement from like poor sleep or recovery, some contributions from low strength or endurance capacity, or just inadequate preparation for the task at hand. It might be that the person has the strength to move slowly, but not the elastic capacity to tolerate speed and repeated energy storage. And that last point actually is really important. Tendons don't only need strength, they need to tolerate the specific type of load being asked of them. A slow calf raise is not the same thing as sprinting. A goblet squat is not the same thing as repeated jumping and landing. And shoulder external rotation with a band is not the same thing as pitching. So if someone's rehab only restores slow strength, but they return to high-speed elastic demands, they will not be fully prepared for what they need to be doing, right? And that is why rest fails as a long-term strategy if that's the only thing that is being executed. It can help calm symptoms, it help reduce pain, and it may be appropriate for a short period of time when the tendon is extremely irritable, but rest does not rebuild capacity. So removing from provocative loads and forces is key, but you also got to layer in some simple loading strategies to help restore capacity, right? And then progress from there. Because if the underlying tissue is that it cannot tolerate a certain demand, then eventually we have to rebuild the ability to tolerate that demand, right? Very simple concept, and I'm saying it often just so I can drive the point home, right? And this is where the phrase load management can sometimes be misunderstood. Load management does not just mean doing less. It means matching the current load to the current capacity and gradually building capacity over time. Cardoso and colleagues in a study that I'll link in the show notes summarized this well in their paper on current trends in tendinopathy management. They noted that the principles of tendinopathy management revolve around education, load monitoring and management, exercise-based rehabilitation, and adjunctive interventions for pain. And that is as a great clinical framework. Education, load management, exercise-based rehab, and adjuncts when appropriate. But the foundation is not passive treatment. The foundation is active restoration of capacity. Now let's talk about evaluation. Tendinopathy is primarily a clinical diagnosis. A classic tendon presentation is localized pain. Usually the patient can point out the painful region with one or two fingers. Achilles tendinopathy, for example, may be located to the mid portion of the Achilles or near the insertion. Patellar tendinopathy is often localized around the inferior pole of the patella. Lateral elbow tendinopathy is typically located around the lateral epicondyle and common extensor tendon region we mentioned earlier. Rotator cuff tendon pain may be more variable, but often presents with pain during resisted shoulder movement, overhead activity, or throwing. The pain is usually load related. It shows up with tasks that load the tendon itself. For the Achilles tendon, that might be running, jumping, stairs, calf raises, or hopping. For the patellar tendon, that might be jumping, landing, squatting, decline squats, or deceleration. And for the lateral elbow, that might be gripping, lifting, pulling, typing, wrist extension under load. And then for the rotator cuff, it might be throwing, pressing, overhead activity, resisted external rotation, things like that. And then stiffness after inactivity, commonly like in the morning after getting up. This can also be common in tendon presentations, but even when the presentation seems obvious, we still have to rule out competing diagnoses or other mechanisms. Just because pain is near a tendon does not mean the tendon is the only driver. Ruling out neurodynamics, for example, you need to also consider joint pathology, bird pain from a trigger point, acute tears, and systemic contributions as well, like different metabolic cascades and just the general health of the individual. And I think a big one that I'll jump back to is the neurodynamics, ruling out any sort of nerve involvement that might mimic pain of a tendinopathy. For example, I just had a case in the clinic that I work at, Parker Performance Institute, where the patient put on their complaint, tennis elbow, and it was actually a radial nerve entrapment that was causing the pain presentation. All orthopedic examinations for the pathology of the extensor tendon, the common extensor tendon that attaches to the lateral epicondylitis, all those tests were negative. Palpation did produce pain at the common extensor tendon, but what was important to do was try to rule out neurodynamics. However, the neurodynamic test with differentiation for the radial nerve there reproduced the chief complaint. So evidence right there to not rule out, or to not forget to rule out neurodynamics or other contributions to someone's pain. Anyway, moving on. So all this matters, especially if someone has particularly sudden severe weakness or traumatic onset, significant swelling or systemic symptoms, night pain, progressive neurologic findings, or presentation that does not behave like a tendon case. These are when some red flag situations might come up. It's always good to do your due diligence with ruling things out. So the clinical process should not simply be, it hurts near a tendon, therefore it's tendinopathy. Or there's an acute spike in workload, so therefore it's tendinopathy. The better process is layering everything together, right? Stacking all the things from the history and the exam. So considering the history, symptom behavior, palpation, functional testing, orthos, load response, and ruling out what should not be missed. Then from there, you can begin to classify irritability. Is this tendon highly reactive? Is it moderately irritable? Is it relatively stable but weak and underprepared? That classification matters because it determines the entry point into care, into the loading strategies and where you'll go from there. A highly irritable tendon may need a period of load reduction, isometrics, pain modifying strategies, and very controlled exposure. A less irritable tendon may tolerate isotonic loading, heavy slow resistance, and more direct strengthening. A tendon that has strength but no elastic capacity may need progression into speed, plyometrics, and sport-specific loading. Usually this will be the end portion of the progression into load, but you need to take into consideration where the person's at, where the person's at that you're working with. And this is why tendinopathy rehab is not just about selecting exercises. You truly got to consider where the person's at and what is the correct choice for the right time and what they're presenting with and what the tissue you're dealing with too. The many different tendons may need different styles of load, like we just talked about, with some being energy storage and release and being spring-like, being energy transfer. So all this comes into consideration when determining what to do for a particular tendon, right? So let's continue on with patient education, which is huge when it comes to load management. This is one of the most important parts of tendon rehab because people often come in frustrated. They may have tried rise or stretching, massage, compression, taping, anti-inflammatories, etc., etc. Some of those things may have helped temporarily, but symptoms keep coming back. So the patient needs to understand what is happening. I would explain it something like this to the person that I'm working with. Your tendon, let's say your tendon is not necessarily damaged beyond repair. There's hope for you here, right? But right now it's not tolerating the loads you are asking it to handle. Our job is to calm symptoms enough to find an entry point, then progressively rebuild the tendon and the entire system's ability to tolerate load. That is a different message than stop everything until it feels better, because if they stop everything, they may feel better in the short term, but they may not be more prepared. And then the cycle will just keep continuing. Another key point is that some discomfort during tendon rehab may be acceptable. Not may be acceptable, is acceptable. We do not necessarily need every exercise to be completely pain-free, although that it depends on the irritability and the individual case. What matters is symptom behavior during the activity, immediately after the activity, and the next day, about 24 hours post-activity, post-loading session. So when it comes to this, patients need to monitor whether an activity produces an increase in pain 2 hours after, 12 hours after, or 24 hours after loading. This is just a general good rule of thumb and a good way to explain it to patients or clients as well. That is useful because tendons often tell us after the fact whether the load was appropriate. A simple way to explain it is during activity, symptoms should stay tolerable, maybe around 3 to 4 out of 10 if you had to put a number to it. Then after activity, symptoms should settle reasonably. The next morning, symptoms should not be meaningfully worse. Morning pain and stiffness are significantly increased the next day. That might suggest the tendon was overloaded. So Bergendale and colleagues have done important work using pain monitoring models in Achilles tendinopathy. Again, I can attach any literature in the show notes. I did a fair amount of reading before this podcast here and before that presentation I mentioned that will also be in the show notes. And for a presentation I have coming up actually in June, whenever you're listening to this, June 2020, Parker Seminars, Miami. If you're in the chiropractic space and want to come check it out. It'll be a fun time. Just subtle plug there. Anyway, I'll continue. So this article I'm talking about right now, their work supports the idea that we're talking about here, that complete rest from activity is not necessary. Again, it can be helpful, but not always necessary. Activity should be guided by symptom response, and that is a helpful middle ground between shut everything down and between the push through no matter what, the pain equals gain sort of mentality. So let's continue on into rehabilitation and some loading strategies here. A very practical way to think about tendon rehab is 4 stages. Stage 1 being desensitization and finding the entry point. Stage 2 being building strength and tendon capacity. Stage 3 being restore speed and energy storage. And stage 4 being return to activity or sport-specific demand. This is the same general progression that shows up in the slides that I've attached to the show notes. General progression or stages you could think about are isometric exercise is at stage 1, and then isotonic and heavy slow resistance at stage 2, speed and energy storage at stage 3, and sport-specific loading at stage 4. So let's start with stage 1. In stage 1, the goal is not to fix everything. The goal is to find a tolerable entry point and have an analgesic effect. The tendon may be sensitive, and the person may have pain with daily activity. They may be frustrated and guarded, so the goal is to reduce excessive provocative load while introducing a level of load that the tendon can tolerate. This is where isometrics are very useful. Rio and Pham published an influential study on patellar tendinopathy, showing that a single bout of isometric contractions reduced tendon pain immediately for at least 45 minutes in duration. Not the isometric load that is 45 minutes post intervention, right? So it was a maximal isometric contraction, so the maximal voluntary isometric contraction that they did in the study. And they also found a reduction in cortical inhibition, which gives us insight into a potential nervous system mechanism at play with tendinopathy here. And this is one of those studies that really shaped a lot of clinical thinking around isometrics for tendon pain. And when it comes to the actual protocol or implementation or dosage of the isometrics here, the protocol that was discussed is a 5 sets of 45-second isometric hold, often at heavy but tolerable intensity, with about 2 minutes of rest between sets. For patellar tendinopathy, that might be a Spanish squat, for example, or a wall sit. For Achilles tendinopathy, that might be mid-range, not in range, mid-range calf raise. The Achilles tendon is sensitive to compression. That's why you wouldn't want to do an in-range position there. Go for mid-range for that Achilles tendon. And then moving on to lateral elbow tendinopathy. For this might be a resisted wrist extension isometric. For example, you could use like a Tyler twist rod and just hold that position. And then for rotator cuff related tendon pain, it might be shoulder external rotation isometrics, or even farmer's carry. That's honestly my favorite way to implement it, as long as they can tolerate it early on. But here's where we do need to be careful and evidence informed. Isometrics are certainly not magic, even though they really are a home run in tendon loading, and they're not universally superior, right? Depends on the person, depends on the tendon even, right? So not every patient responds the same way. That's important to recognize and monitor the response to load. And even some later studies after the one by Rio and Pham have some mixed findings, really, when it comes to this protocol that was implemented in this study. Again, that just shows you that there is versatility and variability when it comes to application of this isometric protocol to tendinopathy. And this variability occurs with any sort of strategy that you're using with care, working with people in general, right? So some people respond very well and some do not. So the principle is not every tendon needs isometrics. The principle is use a tolerable loading strategy that can reduce sensitivity, improve confidence, and create an entry point into progressive loading. That is the real takeaway from that paper and some other evidence surrounding the protocol for tendon loading. Now let's talk about some blood flow restriction training. Blood flow restriction training, or BFR, is an interesting tool because it changes the physiological environment of exercise. With BFR, a cuff is applied to partially restrict venous return while maintaining arterial inflow. This allows low-load exercise to create a higher level of metabolic stress. From a rehab standpoint, that matters because there are many situations where a person cannot tolerate high mechanical loads. They may have pain, they may have post-operative precautions, they may have joint irritation, they may have poor load tolerance, they may be deconditioned, they may have an irritable tendon that does not tolerate heavy resistance just quite yet. And in those situations, BFR may help bridge that gap between underloading and higher load resistance training. Burton and McCormack published a scoping review on BFR resistance training and tendon rehabilitation. The goal was to identify current evidence on BFR and tendon injuries in healthy tendons, looking at intervention parameters, physiological effects, and outcomes. The review suggests BFR may have value, but also makes it clear that evidence is certainly still developing and protocols are variable. Surprise, surprise. So clinically, I would not present BFR as a miracle tendon treatment either. I would present it as a bridge. It may allow us to create a meaningful stimulus when heavier loads are not yet tolerated. That can be very valuable in earlier phases of rehab, especially when the alternative is doing almost nothing. For example, with patellar tendinopathy, someone may not tolerate heavy squatting or high volume jumping. But when it comes to loading strategies, they might tolerate a lower load, knee extension, or leg press variations, and slapping on a BFR cuff may be a great way to increase the metabolic demand there. With Achilles tendinopathy, someone may not tolerate heavy calf loading just yet, but they may tolerate low load calf raises with BFR while gradually progressing toward heavier loading. In a post-operative setting, for example, BFR may help maintain or restore muscle capacity when heavy loads are restricted. But again, BFR is not the destination. It is simply a tool that may help create a physiological stimulus while respecting current mechanical tolerance. Eventually, the person still needs progressive exposure to heavier, faster, and more specific demands. And that brings us to stage 2, isotonic loading and heavy slow resistance. Once symptoms are better controlled and the tendon can tolerate more load, the goal shifts toward strength and capacity. For a long time, eccentric loading was viewed as the primary approach to tendinopathy. Eccentrics can absolutely be effective, but the literature has moved toward a broader understanding at this point. The key principle is progressive loading. Bayer and Pham compared a heavy, slow resistance training protocol with traditional eccentric training in mid-portion Achilles tendinopathy. Both groups had positive and lasting clinical results. The heavy, slow resistance was associated with higher compliance and a trend toward greater patient satisfaction at the 12-week mark in the study. And that matters because it tells us we should not be dogmatic when it comes to tendon loading, the best practices, and that goes really for any facet of working with people in a clinical or performance setting, or just anything in life for that matter. But anyway, I'm not here to get too deep in the weeds on the eccentric training. Definitely can work, and heavy slow resistance certainly can work. Isometrics, like we talked about earlier, can certainly be useful as well. BFR may help in selected cases if there's no contraindications for vascular occlusion. And the real principle here is matching the loading strategy to the patient's current presentation and progressing appropriately. Heavy slow resistance is valuable because it allows controlled, progressive, measurable loading. It can improve muscle strength, tendon stiffness, and load tolerance. It gives us a way to build capacity without immediately introducing high-speed, elastic demands. And for Achilles tendinopathy, this might include seated calf raises, standing calf raises, leg press calf raises, and progressive loading through different knee positions as well. For patellar tendinopathy, for example, this might include leg extensions, Spanish squats, goblet squats, split squats, hack squats, or leg press variations. For lateral elbow tendinopathy, this might include wrist extension, gripping progressions, pronation and supination, under load, and eventually more integrated upper extremity loading. And moving on to rotator cuff related tendon pain, this might include external rotation, scaption, carries, rows, pressing progressions, and eventually higher speed deceleration work. This phase is where we really start to build the foundation. But here is an important point as well. Strength is in fact necessary, but it may not be sufficient. Tendon can become stronger under slow conditions and still be underprepared for speed. That leads us to stage 3, speed and energy storage. This is where tendon rehab often breaks down. The person feels better, they get stronger, they can do their slow strength work, their pain is lower, and everyone feels good, right? Everyone's happy, but the story doesn't end. They go back to sprinting, they go back to jumping, they go back to cutting and throwing or whatever high volume sport activity they're engaging in, and then symptoms return. Tale as old as time, right? And why is this? Because the tendon was not prepared for the rate and nature of the loading. Tendons are not just force transmitters, they are energy, storage, and release structures. Running, jumping, sprinting, throwing, they all involve rapid loading and unloading. That is a different demand than slow resistance training. So we need to restore elastic capacity And when it comes to the Achilles tendon, this may include pogos, jump rope, skipping, hopping, bounding, and graded running progressions. With patellar tendinopathy, this might include landing mechanics, snap downs, jump squats, repeated jumps, deceleration drills, cutting drills, and other sport-specific jumping volume. For the rotator cuff-related tendon pain in a thrower, this may include med ball throws, plyometric ball drills, eccentric deceleration work, rhythmic stabilization, and graded throwing, introduction to a graded throwing program as well. The key here is that speed adds load. A person may tolerate slow, heavy loading, but not tolerate fast, elastic loading. That does not mean slow loading has failed. It means slow loading was the first phase of that preparation, right? So when we add speed, we monitor the response carefully, as we do with anything there. And we got to ask ourselves, does pain increase during the session? Does it settle afterward? Is the tendon worse the next morning? The 24 hours after, for example, like we talked about earlier, does the stiffness increase? Does the person lose confidence, right? That's important to consider as well. These responses guide progression. Then moving on to stage 4. Stage 4 is return to activity or support-specific demand. This phase has to be specific to the person. A runner needs running, a basketball player needs jumping, landing, deceleration, cutting, and repeated efforts. A baseball pitcher needs throwing volume, posterior cuff deceleration, trunk and hip sequencing, and workload progression. A CrossFit athlete, for example, needs repeated loading across squatting, jumping, pulling, pressing, and working under fatigue. A manual laborer needs lifting, carrying, gripping, kneeling, reaching, and an endurance. This is where we have to ask, what is the actual demand this person needs to tolerate? Because if we do not know the goal, we cannot build the bridge. This is why I like the idea of defining the basement and the ceiling. The basement is where the patient is right now. What can they currently tolerate, right? And the ceiling is where they need to go. What does their sport, their work, their training, their life require? The rehab plan is the bridge between those 2 points. So now let's talk briefly about tendon biology, laying some more of that foundation there. Mechanical loading matters because tendon tissue responds to mechanical stress. Tendon cells or tenocytes sense loading and respond through cellular signaling and changes in extracellular matrix turnover. There's another study that I'll include in the show notes by Kaiser and colleagues that discusses mechanical loading influences on collagen synthesis, structural changes, and tendon function. And this is where we can connect loading to mechanotransduction. Mechanical load is not just something imposed on the tendon, it becomes a biological signal that can influence tissue remodeling. And a more recent review actually on tendon healing also highlights that tendon healing involves inflammatory, proliferative, and remodeling phases with growth factors such as TGF-beta, IGF-1, VEGF, PDGF, and other contributors to the healing environment itself from a chemical standpoint, which is quite fascinating. And again, all that will be linked in the show notes for you. It also emphasizes that mechanical loading throughout the process is important for proper healing. That is important because it helps us understand why load really does matter. We're not just strengthening muscles around the tendon. We're not just trying to influence the tissue environment or the nervous system or the kinetic chain or the patient's capacity to tolerate meaningful demand. It all comes together, right? It's multifactorial, and we're looking at all the factors that go into the person, what they're experiencing, what the load they have to be prepared for, and what's contributing to their symptom presentation, right? So this adaptation to getting ready for their meaningful demands, right? That takes time. Pain can change quickly, like we talked about with the analgesic effect with isometrics, but the tissue capacity often changes more slowly. That is why the patient may feel better before they're actually prepared. And that is also why rehab should not just stop at symptom reduction. So let's also actually talk about adjuncts. There are many interventions used for tendinopathy: soft tissue work, manual therapy, dry needling, taping, orthotics, shockwave, injections, and many more modalities for that matter. Some of these may have a role depending on the case, but we have to be honest. We have to be honest with, hey, what actually works? Do we really just want to throw things at it? Psychological component exists too, with rubbing the boo-boo and doing things that from a more passive standpoint for the patient or client, whomever you're working with. If the if the core problem is low tolerance, then passive interventions alone are not enough. They can be helpful, but they are not enough. They may reduce pain. They may create a window of opportunity to introduce load. They may improve comfort. They may help the patient move, but they do not progress. They do not replace that progressive loading strategy that we talked about in the earlier portion of this discussion here. And I think this is where clinicians and coaches need to be careful to not confuse symptom modulation with rehabilitation. Symptom modulation may be a part of rehab, but rehabilitation is restoring function, capacity, and confidence as well. So let's give a few practical examples as we near the end here. First, Achilles tendinopathy. Imagine a 23-year-old sprinter who returns to training after several months off and develops localized mid-portion Achilles pain. They have morning stiffness, pain with hopping, and pain with single left calf raises. That can even be some diagnostic criteria there. Pain with that single left calf raise and with hopping as well. And in the history, it may have revealed an increase in training load too quickly. Early on in this rehab scenario here, we might reduce sprinting, high-speed plyometric work, provocative loads, right? We might use isometric calf holds in a tolerable range as the early intervention strategy. If the tendon is very irritable, we may start with bilateral work or supported single leg work. And from there, we build into heavy, slow calf raises. Then we progress to both seated and standing variations because the soleus and gastrocnemius both matter. They both contribute to the Achilles tendon. And then lastly, we move to pogo, skipping, hopping, running, progressions, sprint drills, and into the full speed exposure and sport specific exposure. Next, for an example to kind of drive some points home here, are patellar tendinopathy. Imagine a basketball player with localized pain at the inferior pole of the patella. Jumping and landing are provocative. A single leg squat on a decline reproduces the chief complaint. They feel better with some rest, but symptoms return as they resume basketball. Early on, Spanish squat isometrics or leg extension isometrics may be useful if they reduce pain. Then we build into slow isotonic quadricep loading, squats, split squats, leg press, and eventually heavier strength work. And then once strength improves, we restore landing mechanics, working on their actual form to see if everything is appropriately accepting load. Then we restore jump tolerance, repeated jumps, deceleration, cutting, and then basketball specific volume. Third example here will be the lateral elbow tendinopathy. Someone has lateral elbow pain with gripping, for example, and then lifting and in wrist extension. Let's say that's the presentation there. And the mistake is too often to only massage the forearm or involve or even avoid gripping, as a whole. But instead, we need to identify current tolerance, and then the isometric wrist extension may be a great entry point here. Then we progress into the eccentric, wrist extension, gripping, pronation and supination, carries, rows, and then, of course, into the specific task that they're trying to get into, whether that's tennis, pickleball, manual work, things like that. So again, the same stages, the stage 1, 2, 3, 4 that we laid the groundwork for earlier. Then another example here that I'll give is rotator cuff tendon pain. Say it's a thrower that has pain with high intensity throwing. They may tolerate basic strengthening, but not high speed, but not like at their follow through of their throw there. And the rehab may start with isometrics or like a farmer's carry and into controlled rotator cuff loading, and then progress into eccentric posterior cuff work scapular and trunk integration, plyometric ball drills, and then finally into the graded throwing program. So across all these examples, the principle is the same. Desensitize, build strength, restore speed, capacity, force transfer capacity, and return to the specific demand. And now I want to close with a practical framework that you can easily remember, right? Step 1, rule out. Make sure this is actually a tendon presentation and not something that requires a different pathway or different strategies. Always try to find the most dominating mechanism in what is truly the contributor to the chief complaint. Step 2, classify irritability. High reactive tendons need a different entry point than stable but weak tendons. Step 3, manage load. Remove or reduce the biggest provocative forces or movements or positions, but do not remove all stimulus forever. Educate the patient through this. That is not a forever thing. Step 4, choose an entry point. That could be isometrics, low load isotonic work, blood flow restriction, modified movement, or even other tolerable loading strategies. Step 5, build capacity, progress strength, progress volume, range, and intensity. Step 6, restore energy storage, adding speed, plyometrics, elastic loading, and repeated efforts. Step 7, return to the person's actual goal. Sport, work, training, recreation, life, whatever their meaningful activity is. And then step 8, maintain that capacity. Give them the tools to maintain it. Tendon health often requires ongoing loading. So here are the big takeaways. Tendinopathy is best understood clinically as tendon pain with dysfunction. It is often a load tolerance problem, load management problem. Rest may calm symptoms, but it does not restore capacity. Imaging can help, but structure must be interpreted in the context. Then education, load monitoring, and progressive exercise are central to management. That's definitely a key takeaway there. And isometrics may help reduce pain. In some cases, I know it's the classic, and it's honestly my go-to, of course, but keep an open mind about it is always important. Then heavy slow resistance, moving on, heavy slow resistance and eccentric training can both be effective, as well as blood flow restriction may be useful as a bridge. When heavy loading is not tolerated, speed and energy storage must be restored before return to higher level activity. And then lastly, as kind of I'm ripping out these final takeaways, the goal is not just a quiet tendon. The goal is a capable, robust tendon. The goal is a person who can return to the activities that they care about with confidence, resilience, and the physical capacity to tolerate the demands of their life. That is the bigger picture. Not just pain relief, but capacity. Not just rest and taking it easy, but adaptation and getting prepared for what comes next, getting prepared for what their goal is and what they want to be prepared for. So those are just some final takeaways there from the tendon loading and tendinopathy conversation. I hope this was very helpful for you. If you ever have any questions, feel free to leave a comment on whatever you may be listening to this on, or reach out to me via email at coach@kingdomstrengthinstitute.com. Here for you if you ever need anything. God bless you and enjoy. Catch you on the next episode.